Hi everyone, this is Doc Ina and this is my lecture on thromboembolism in pregnancy. To download my lecture deck, please go to my WordPress site, Doc Ina Obigaine. References for this lecture are the following: Williams Obstetrics 25th edition and ACOG Practice Bulletin 2018. And this is the outline of my lecture. So Rudolf Virchow postulated that stasis, local trauma to the vessel wall, and hypercoagulability predispose to venous thrombosis development, and the risk for each of these increases during normal pregnancy. For example, compression of the pelvic veins and inferior vena cava by the enlarging uterus renders the lower extremity venous system particularly vulnerable to stasis. This stasis is the most constant predisposing risk factor for venous thrombosis. Venous stasis and delivery may also contribute to endothelial injury. Pregnancy also alters the levels of coagulation factors normally responsible for hemostasis. The overall effect of these changes is an increased thrombogenic state. So this table shows to us the changes in the normal functioning of the coagulation system during pregnancy. So as you can see here, most coagulant factors are increased or physiologically increased during pregnancy, such as fibrinogen, factor 7, 8, and 10, von Willebrand factor, and plasminogen activator inhibitor 1 and 2. When DVT occurs during pregnancy, it is more likely to involve the left lower extremity and to be more proximal, involving the iliac and iliofemoral veins in comparison with the non-pregnant women. This distribution has been attributed to increased venostasis in the left leg related to compression of the left iliac vein by the right iliac artery, and this is what we call the May-Thurner syndrome or the iliac vein compression syndrome. Here are the risk factors for developing thromboembolism during pregnancy. The risk of VTE may be higher in the third trimester compared with the first and second trimesters, but the increased risk of VTE is present from the first trimester, often before many of the anatomic changes of pregnancy occur. The risk of VTE is higher during the postpartum period than it is during pregnancy, especially during the first week postpartum. The most important individual risk factor for VTE in pregnancy is a personal history of thrombosis. The risk of recurrent VTE during pregnancy is increased threefold to fourfold, and 15 to 25% of all cases of VTE in pregnancy are recurrent events. The next most important individual risk factor for VTE in pregnancy is the presence of thrombophilia. Thrombophilia is present in 20 to 50% of women who experience VTE during pregnancy and the postpartum period. Both acquired and inherited thrombophilias increase the risk of VTE. So now we talk about thrombophilias. So under thrombophilia, we have the inherited and the acquired thrombophilia. Patients with inherited thrombophilic disorders often have a family history of thrombosis. This is also found in patients who present with the following: venous thromboembolism before the age of 45 years old, especially in the absence of well-recognized risk factors such as surgery or immobilization; venous thromboembolism with minimal provocation such as after a long-distance flight or after taking estrogens; or a family history of sudden death due to pulmonary embolism, or a history of multiple family members requiring long-term anticoagulation therapy because of recurrent thrombosis. And here's a list of the inherited thrombophilias. We have antithrombin deficiency, protein C and S deficiency, activated protein C resistance, factor V Leiden mutation, prothrombin mutation, hyperhomocystinemia, and other thrombophilia mutations. On the other hand, we have acquired thrombophilias in the form of antiphospholipid antibody syndrome, heparin-induced thrombocytopenia, and cancer. So we'll talk about antiphospholipid antibody syndrome in this lecture. This prothrombotic disorder can affect both the venous and arterial circulations. The deeper veins of the lower limbs and the cerebral arterial circulation are the most frequent sites of venous and arterial thrombosis respectively. Besides thrombosis, the other major clinical manifestations of APAS are obstetrical. The criteria to diagnose APAS include at least one otherwise unexplained fetal death at or beyond 10 weeks, at least one preterm birth before 34 weeks gestation because of eclampsia, severe preeclampsia, or placental insufficiency, or at least 3 unexplained consecutive spontaneous abortions before 10 weeks. Patients should be tested for the presence of three factors, and these are lupus anticoagulant, anticardiolipin immunoglobulin G and M or IgG and IgM antibodies, and anti-beta-2 glycoprotein 1 IgG and IgM antibodies. Anticardiolipin antibody is the most common sole antiphospholipid antibody present. Anti-beta-2 glycoprotein 1 is associated with the lowest live birth rate and highest incidence of preeclampsia, fetal growth restriction, and stillbirth compared with anticardiolipin antibodies or lupus anticoagulant alone. Despite therapy with low-dose aspirin and prophylactic low molecular weight heparin, the chance of a live burn unit was only 30% for women with positive test results for all of these three antibodies. The thrombosis risk rises significantly during pregnancy in women with APAS. The ACOG notes that a definitive causal link cannot be made between inherited thrombophilias and adverse pregnancy outcomes. In contrast, the association between APAS and adverse pregnancy outcomes, including fetal loss, recurrent pregnancy loss, and preeclampsia, is much stronger. The ACOG recommend that thrombophilia screening can be considered in the following clinical circumstances. Number 1, a personal history of VTE that was associated with a non-recurrent risk factors such as fractures, surgery, and/or prolonged immobilization. And number 2, a first-degree relative, that's a parent or a sibling, with a history of high-risk thrombophilia or VTE before age 50 years old in the absence of other risk factors. The ACOG states that testing for inherited thrombophilias in women who have experienced recurrent fetal loss or placental abruptio is not recommended. Testing is not recommended for women with a history of fetal growth restriction or preeclampsia. Screening for antiphospholipid antibodies may be appropriate in women who have experienced fetal loss or early onset preeclampsia. Lab testing is performed at 6 weeks after the thrombotic event, while the patient is not pregnant and when she is not receiving anticoagulation or hormonal therapy. Screening for hyperhomocystinemia is not recommended. And here are some of the ways to test for thrombophilia. For example, if we want to test for factor V lead-in mutation, then the testing method would be activated protein C resistance assay, and so on and so forth. Now we go to deep vein thrombosis. During pregnancy, most venous thromboses are confined to the deep veins of the lower extremity. Approximately 70% of cases are located in the iliofemoral veins without involvement of the calf veins. The signs and symptoms vary greatly and depend on the degree of occlusion and the intensity of the inflammatory response. The two most common initial symptoms of DVT, present in more than 80% of women with pregnancy-associated DVT, are pain and swelling in an extremity. The thrombus typically involves much of the deep venous system to the iliofemoral region. Reflex arterial spasm causes a pale, cool extremity with diminished pulsations. Calf pain, either spontaneous or in response to squeezing or to Achilles tendon stretching, that's the Hohmann's sign, may be caused by a strained muscle or contusion. Now, this figure is a diagnostic algorithm recommended by the American College of Chest Physicians that we can use for evaluation of pregnant women that we suspect to have deep vein thrombosis. So, as we see here, when we suspect pregnant women to have deep vein thrombosis, we do proximal compression ultrasound. If it's positive, then we treat. If it's negative, then we can do a sensitive D-dimer testing or repeat proximal compression ultrasound on days 3 and 7. If the repeat proximal compression ultrasound on day 3 and 7 is positive, then we treat. If the D-dimer testing is negative, then no further testing is needed. If the proximal compression ultrasound is negative but isolated iliac vein thrombosis is suspected, then we can do Doppler ultrasound of the iliac vein or do CT or MRI or venography. The ACOG recommend compression ultrasonography of the proximal veins as the initial diagnostic test. According to the American College of Chest Physicians, this non-invasive technique is currently the most used first-line test to detect deep vein thrombosis. The diagnosis is based on the non-compressibility and typical echo architecture of a thrombosed vein. In pregnant women, normal findings with venous ultrasonography do not always exclude a pulmonary embolism, and this is because the thrombosis may have already embolized or because it arose from iliac or other deep pelvic veins, which are less accessible to ultrasound evaluation. Thrombosis associated with pulmonary embolism during pregnancy commonly originates in the iliac veins. How about MRI? This imaging technique allows excellent delineation of anatomical detail above the inguinal ligament. MRI is immensely useful for diagnosis of iliofemoral and pelvic vein thrombosis. How about D-dimer screening test? Screening with a D-dimer test in pregnancy is problematic for several reasons. D-dimer serum levels rise with gestational age along with substantively elevated plasma fibrinogen concentrations, and levels are also affected by multifetal gestation and cesarean delivery. D-dimer concentrations can also be elevated in certain pregnancy complications such as placental abruptio, preeclampsia, and sepsis syndrome. And therefore, D-dimer screening test is not really recommended as part of the evaluation of VT in pregnancy or the postpartum period. So how do we manage deep vein thrombosis? Treatment of DVT is with anticoagulation and limited activity. If thrombophilia testing is performed, it is done before anticoagulation. Heparin induces a decline in antithrombin levels and warfarin lowers protein C and S concentrations. Anticoagulation is initiated with either unfractionated heparin or low molecular weight heparin, which is the most recommended. There's preferential use of low molecular weight heparin during pregnancy because of better bioavailability, longer plasma half-life, more predictable dose response, reduced risk for osteoporosis and thrombocytopenia, and less frequent dosing. During pregnancy, heparin therapy is continued, and for postpartum women, anticoagulation is begun simultaneously with warfarin. Pulmonary embolism develops in as much as 60% of patients with untreated venous thrombosis, and anticoagulation decreases this risk to less than 5%. Elastic stockings are fitted, and anticoagulation is continued. Graduated compression stockings are continued for 2 years after the diagnosis to reduce the incidence of post-thrombotic syndrome. And this syndrome can include chronic leg paresthesias or pain, intractable edema, skin changes, and leg ulcers. For unfractionated heparin, they should be considered for the initial treatment of thromboembolism and in situations in which delivery, surgery, or thrombolysis may be necessary. This can be administered by one of two alternatives. First is initial IV therapy followed by adjusted dose subcutaneous unfractionated heparin given every 12 hours. And the second is a twice daily adjusted dose subcutaneous unfractionated heparin with doses adjusted to prolong the activated partial thromboplastin time into the therapeutic range 6 hours post-injection. The therapeutic dose for subcutaneous UFH is usually 10,000 units or more every 12 hours. For IV therapy, several protocols are acceptable. In general, if unfractionated heparin is used, it is initiated with a bolus IV dose of 70 to 100 units per kilogram, which is about 5,000 to 10,000 units. This is followed by continuous IV infusion beginning at 1,000 units per hour or 15 to 20 units per kilogram per hour. This infusion rate is titrated to achieve an APTT 1.5 to 2.5 times control values. IV anticoagulation is maintained for at least 5 to 7 days, after which treatment is converted to subcutaneous heparin to maintain an APTT to at least 1.5 to 2.5 times control throughout the dosing interval. For women with lupus anticoagulant, APTT does not accurately assess heparin anticoagulation, and thus antifactor 10A levels are preferred. In non-pregnant patients with VTE, minimum treatment duration is 3 months. For pregnant patients, the American College of Chest Physicians recommends anticoagulation throughout pregnancy and postpartum for a minimum total duration of 3 months. Prophylactic doses of subcutaneous UFH can range from 5,000 to 10,000 units every 12 hours, titrated to maintain an antifactor 10A level of 0.1 to 0.2 units per ml measured 6 hours after the last injection. If the VTE occurs during the postpartum period, a minimum of 6 months of anticoagulation treatment is recommended. So how about low molecular weight heparin? This comes from a family of derivatives of unfractionated heparin, and their molecular weight averages 4,000 to 5,000 daltons compared with 12,000 to 16,000 daltons for the conventional heparin. And this does not cross the placenta. They exert their anticoagulant activity by activating antithrombin. The primary difference is the relative inhibitory activity against factor Xa and thrombin. UFH has equivalent activity against factor Xa and thrombin, but low molecular weight heparin has greater activity against factor Xa than against thrombin. They also have a more predictable anticoagulant response and fewer bleeding complications than unfractionated heparin because of their better bioavailability, longer half-life, dose-independent clearance, and decreased interference with platelets. These low molecular weight heparin compounds are cleared by the kidneys and must be used cautiously when there is renal dysfunction. Now, this is a table that shows to us the anticoagulation regimen definitions. So, for prophylactic low molecular weight heparin, these are the corresponding anticoagulation dosage. As we can see here, the enoxaparin, dalteparin, tinzaparin. For the intermediate dose low molecular weight heparin, there's anticoagulation dosage written here for enoxaparin and dalteparin, and so on and so forth. Low molecular weight heparins available for use during pregnancy include enoxaparin, tinzaparin, and dalteparin. Enoxaparin can be given at 1 mg per kilogram given twice daily based on early pregnancy weight. And treatment is monitored by peak anti-factor Xa activity at 3 hours post-injection with a target therapeutic range of 0.4 to 1 unit per ml. For tinzaparin, a dose of 75 to 175 units per kilogram per day is necessary to achieve a peak anti-factor Xa levels of 0.1 to 1 units per ml. For dalteparin, the conventional dosing with 100 units per kilogram every 12 hours is insufficient to maintain full anticoagulation, and that's why the slightly higher doses that was shown in the previous table, that's table 52-5, may be required. So how do we monitor this? We monitor by periodic measurement of anti-factor Xa levels 4 to 6 hours after an injection with dose adjustment to maintain a therapeutic level. Low molecular weight heparins are safe and effective. However, the manufacturer of Lovenox, that's enoxaparin, warned that its use in pregnancy had been associated with congenital anomalies and a higher risk of hemorrhage. The ACOG recommends that these risks are rare and that their incidence is not higher than expected, and that no cause and effect relationship has been established. So the ACOG recommends enoxaparin and dalteparin could be given safely during pregnancy. Low molecular weight heparin should be avoided in women with renal failure. When given within 2 hours of cesarean delivery, these agents raise the risk of wound hematoma. Women receiving either therapeutic or prophylactic anticoagulation should be converted from low molecular weight heparin to the shorter half-life unfractionated heparin during the last month of pregnancy or sooner if delivery appears imminent. The purpose of this conversion to unfractionated heparin has less to do with any risk of maternal bleeding at the time of delivery, but rather with neuraxial blockade complicated by an epidural or spinal hematoma. The, the American College of Chest Physicians recommends that women scheduled for a planned delivery who are receiving twice daily adjusted dose subcutaneous unfractionated heparin or low molecular weight heparin discontinue their heparin 24 hours before labor induction or a cesarean delivery. Patients receiving once daily low molecular weight heparin should take only 50% of their normal dose on the morning of the day before delivery. The ACOG advises that adjusted dose subcutaneous low molecular weight heparin or unfractionated heparin can be discontinued 24 to 36 hours before an induction of labor or scheduled cesarean delivery. The American Society of Regional Anesthesia and Pain Medicine advises withholding neuraxial blockade for 10 to 12 hours after the last prophylactic dose of low molecular weight heparin or 24 hours after the last therapeutic dose. If a woman begins labor while taking unfractionated heparin, clearance can be verified by an APTT. Reversal of heparin with protamine sulfate is rarely required and is not indicated with a prophylactic dose of heparin. For women in whom anticoagulation therapy has temporarily been discontinued, pneumatic compression devices are recommended. Vitamin K antagonists are generally contraindicated because they readily cross the placenta and may cause fetal death and malformations from hemorrhages. They do not accumulate in breast milk and are thus safe during breastfeeding. Postpartum venous thrombosis is treated with intravenous heparin and oral warfarin initiated simultaneously. The initial dose of warfarin is usually 5 to 10 milligrams for the first 2 days. Subsequent doses are titrated to achieve an international normalized ratio of 2 to 3. To avoid paradoxical thrombosis and skin necrosis from the early antiprotein C effect of warfarin, these women are maintained on therapeutic doses of unfractionated heparin or low molecular weight heparin for 5 days and until the INR is in a therapeutic range for 2 consecutive days. What are the complications of anticoagulation? Three significant complications associated with anticoagulation are hemorrhage, thrombocytopenia, and osteoporosis. The latter two are unique to heparin, and the risk may be reduced with low molecular weight heparin use. The most serious complication is hemorrhage, which is more likely if there has been recent surgery or lacerations. So there are two types of heparin-induced thrombocytopenia. The non-immune benign reversible thrombocytopenia is the most common and develops within the first few days of therapy and resolves approximately in 5 days without therapy cessation. The second type is a severe form of heparin-induced thrombocytopenia, which results from an immune reaction involving IgG antibodies directed against complexes of platelet factor 4 and heparin. We also have heparin-induced osteoporosis, and this is bone loss that may develop from long-term heparin administration, usually 6 months or longer, and this is more prevalent among cigarette smokers. Unfractionated heparin can cause osteopenia, and this is less likely with the use of low molecular weight heparins. Women treated with any heparin should be encouraged to take an oral daily dose of calcium at 1,500 milligrams per day. Anticoagulation in abortion. The treatment of deep vein thrombosis with heparin does not preclude pregnancy termination by careful curettage. After the products are removed without trauma to the reproductive tract, full dose heparin can be restarted in several hours. How about for delivery? The effects of heparin and blood loss at delivery depend on several variables, and these are the dose, route, and timing of administration, number and depth of incisions and lacerations, intensity of postpartum myometrial contractions, and the presence of other coagulation defects. Blood loss should not be greatly increased with vaginal delivery if the episiotomy is modest in depth, there are no lacerations, and the uterus promptly contracts. The ACOG recommends restarting unfractionated heparin and low molecular weight heparin no sooner than 4 to 6 hours after vaginal delivery or 6 to 12 hours after cesarean delivery. Slow IV administration of protamine sulfate generally reverses the effect of heparin promptly and effectively. It should not be given in excess of the amount needed to neutralize the heparin because it also has an anticoagulant effect. Now let's talk about pulmonary embolism. Dyspnea, chest pain, cough, syncope, and hemoptysis are some of the clinical signs and symptoms of pulmonary embolism. Other predominant clinical findings include tachypnea, apprehension, and tachycardia. In some cases, an accentuated pulmonic closure sound, RALS, and/or friction rub may be heard. Right axis deviation and T-wave inversion in the anterior chest leads may be evident on the electrocardiogram. Chest radiography results may be normal but may also show findings such as atelectasis, infiltrates, cardiomegaly, or effusion. Alveolar arterial oxygen tension difference is a useful indicator of the disease. More than 86% of patients with acute pulmonary embolism will have an alveolar arterial difference that's greater than 20 mm Hg. Massive pulmonary embolism is defined as embolism causing hemodynamic instability. Acute mechanical obstruction of the pulmonary vasculature causes increased vascular resistance and pulmonary hypertension followed by acute right ventricular dilatation. In otherwise healthy patients, significant pulmonary hypertension does not develop until 60 to 75% of pulmonary vascular tree is occluded. Circulatory collapse requires 75 to 80% obstruction, and most acutely symptomatic emboli are large and likely a saddle embolism. If there is evidence of right ventricular dysfunction, the mortality rate approaches 25%. It is important in these cases to infuse crystalloids carefully and to support blood pressure with vasopressors. Oxygen treatment, endotracheal intubation, and mechanical ventilation are completely preparatory to thrombolysis, filter placement, or embolectomy. So, how do we diagnose massive pulmonary embolism? The exposure of the mother and the fetus to ionizing radiation is always a concern when investigating a suspected pulmonary embolism during pregnancy. However, this concern is largely overruled by the hazards of missing out a potential fetal diagnosis. Moreover, erroneously assigning a diagnosis of pulmonary embolism to a pregnant woman is also fraught with problems. It unnecessarily exposes the mother and the fetus to the risk of anticoagulation treatment and will impact delivery plans, future contraception, and thromboprophylaxis during subsequent pregnancies. The American Thoracic Society and the Society of Thoracic Radiology developed an algorithm for the diagnosis of pulmonary embolism during pregnancy. So, if we suspect our patient to have pulmonary embolism, then we check the leg symptoms. If present, then we do compression ultrasonography. If it's positive, then we treat accordingly. If it's absent, then we proceed to doing chest x-ray, of course with abdominal shield. If it's normal, then we do the ventilation perfusion scan. If it's abnormal, then we do the CTPA, or that's the computed tomographic pulmonary angiography. Computed tomographic pulmonary angiography, or CTPA, is a multi-detector computed tomography with pulmonary angiography and is currently the most commonly employed technique used for pulmonary embolism diagnosis in non-pregnant patients. The estimated fetal radiation exposure averages about 0.45 to 0.6 milligray. The ventilation perfusion scintigraphy, or lung scan, this technique involves a small dose of radiotracer such as IV administered technetium-99m macroaggregated albumin. There is negligible fetal and maternal breast radiation exposure at 0.1 to 0.4 milligray. The scan may not provide a definite diagnosis because many other conditions can cause perfusion defects, such as pneumonia or local bronchospasm. For intravascular pulmonary angiography, this requires catheterization of the right side of the heart and is considered the reference test for pulmonary embolism. Disadvantages, however, are the following: higher radiation exposure for the fetus, it's time consuming, uncomfortable, and associated with dye-induced allergy and renal failure. It is only reserved for confirmation when less invasive tests are equivocal. So, how do we manage massive pulmonary embolism? Immediate treatment for pulmonary embolism is full anticoagulation, similar to that for deep vein thrombosis, and several complementary procedures may be indicated, as we will show you in the following slides. One of which will be vena cava filters. Placement of a vena cava filter should be considered before surgery in a patient on anticoagulants. Indicated also when heparin therapy fails to prevent recurrent pulmonary embolism from the pelvis or legs, or when embolism develops from these sites despite heparin treatment. Such filters can also be used following massive emboli in patients who are not candidates for thrombolysis. Routine filter placement has no added advantage to heparin given alone. Retrievable filters may be used as short-term protection and then removed 1 to 2 weeks later. You can also do thrombolysis. Now, compared with heparin, thrombolytic agents provide more rapid lysis of pulmonary clots and improvement of pulmonary hypertension. Tissue plasminogen activator used during pregnancy has similar complication rates to those in non-pregnant patients. We can do embolectomy. Now, given the efficacy of thrombolysis and filters, surgical embolectomy is now uncommonly indicated. Now, let's talk about thromboprophylaxis. So, as you can see here, these are the recommended pharmacologic thromboprophylaxis in pregnant women in the postpartum period. And this table was lifted from the ACOG Practice Bulletin of 2018. So, for example, clinical scenario of, let's say, no history of VTE on no thrombophilia. The antepartum management would be surveillance without anticoagulation therapy, and the postpartum management would be surveillance without anticoagulation therapy or postpartum prophylactic anticoagulation therapy if the patient has multiple risk factors. So for those of you who are interested to know this recommended pharmacologic thromboprophylaxis, then read on the whole table. So for cesarean delivery, the risk for deep vein thrombosis and fetal thromboembolism increases following cesarean delivery compared with that after vaginal delivery. The ACOG recommended placement of pneumatic compression devices before CS for all women not already receiving thromboprophylaxis. For patients undergoing cesarean delivery with additional risk factors for thromboembolism, both pneumatic compression devices and unfractionated heparin or low molecular weight heparin may be recommended. So, of course, with cesarean delivery comes neuraxial anesthesia. So, this is the recommended timing of neuraxial anesthesia in relation to pharmacologic anticoagulation. So, for example, if the dosage regimen is unfractionated heparin prophylaxis, then we hold the dose for 12 hours and assess coagulation status before administering neuraxial anesthesia. If intrapartum and there's urgent or an emergent procedure, then you hold the dose for 12 hours and assess coagulation status before administering neuraxial anesthesia. However, in urgent cases with greater competing risk from general anesthesia, the placement of neuraxial anesthesia may be appropriate. Now, postpartum, we wait at least 1 hour after neuraxial blockade and catheter removal before restarting heparin. So, in summary, we have talked about the pathophysiology of thromboembolic disorders in pregnancy, and we also talked about the acquired and inherited thrombophilias, deep vein thrombosis, pulmonary embolism, and how to do and the indications for thromboprophylaxis. Thank you for watching. Please don't forget to subscribe in my YouTube channel and my WordPress site, Tokina Obigaine. Thank you.